Very good afternoon. We are just starting our clinic. We were waiting for Madam to join, but it seems Ma'am is busy. So whenever she joins, we ask her for her address. But right now we are starting our clinic. So a very good afternoon and welcome to the Central TB Division, NITRD, and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend a hearty welcome to our DDG ma'am and her team, the directors and teams from NIRT, from NTI, STOs, directors of STDCs, faculty members from Medical College, district TB officers and medical officers. A very warm welcome. Very special welcome to our national expert today, Dr. Salil Bhargav, who has joined us for the first time as the expert, and Dr. K.K. Chopra, who will be the state expert, with the NTF chair, Dr. Ashok Bharadwaj. A very warm welcome. I am Dr. Neeta Singla. I am the Nodal Officer, DRTB Center at NITRD. On my left is Dr. Saroj Meena. She is a senior pulmonologist and the case expert for the day. On the extreme right is Dr. Abhishek, who is the junior resident in the respiratory department and will be presenting the case today. On my right side is Dr. Devika Tail. She is the head department of biochemistry and she has established the therapeutic drug monitoring lab in our institute for both first and second line drugs. A very warm welcome, Dr. Devika. And now I request Dr. Sanjay Gupta sir, who is the head of TB and respiratory department at NITRD, to give his inaugural address as our director is not able to join today. Over to you.
Well, thank you, Dr. Neeta. So from the Institute and from the Department of TB and Respiratory Disease, I welcome everybody for this difficult to treat TB clinic. And as you know, we have already done more than 100 now these clinics. So in today clinic is about our treatment failure case and about diagnosing the hidden causes for the TB treatment failure. So it is an interesting case from NITRD itself, and I welcome Dr. Saroj, who will be the case expert for this case, and the state expert, Dr. Chopra from the NDTB Center, also the national expert, Dr. Salil Bhargav, and the national chair, Dr. Ashok Bharadwaj. Also, a special welcome for our sir, Dr. Rupak Singh sir, for joining this clinic today. Thank you, everyone. Let's, Dr. Neeta, let's start the case. Thank you.
Thank you. Thank you, Dr. Sanjay. It is now my privilege to welcome our DDG madam, Dr. Shobhini ma'am. Ma'am, your presence is a great motivation for all of us, and your unwavering commitment to the program is appreciable. We look forward to your guidance. Over to you, ma'am.
Thank you, Dr. Singla. I wish the session all success. It's great to see all the stalwarts here, Dr. Rupak Singla, Dr. Bharadwaj, Dr. Gupta, and of course your team in NITRD, which is managing the difficult to treat TB clinic. And it is nice to see that there is a good response to this activity, and we have the presence from the field level, from the DTOs, from the various medical colleges, etc. And I look forward to listening to the presenters and enhancing the programmatic understanding on the clinical aspects of tuberculosis. So I'd like to, without much delay, hand back the mic to the organizers to get along with the scientific program. Thank you.
Thank you very much, ma'am. Now we move to our presentation for the day. Today, as a part of statewide case discussion series, we have case from NITRD Delhi. And the case presented is Dr. Abhishek Saini, who's a third-year DNB resident at NITRD. Case expert on my left is Dr. Saroj Meena, who's a specialist in Department of TB and Respiratory Diseases. The state expert will be Dr. K.K. Chopra, who's consultant and ex-director at New Delhi TB Center. The national expert will be Dr. Salil Bhargav. Sir is the Pro-Chancellor and in the department, and he is in Department of Pulmonary Medicine at Amaltas Institute of Medical Sciences. Dr. Salil sir is a professor of respiratory medicine and a pro-chancellor at Amaltas Institute of Medical Sciences. He has a wide experience of teaching and training for last 35 years. He started his career as a district TV officer, so he very much understands the problems at the field level. So, and his sir has been a dean at Gandhi Medical College, Bhopal. Sir, a very warm welcome, and we look forward to your comments. So, with this, we begin today's academic deliberations. Over to Dr. Abhishek for his presentation.
Thank you, ma'am. Good afternoon, everyone. Good afternoon, everyone. It's my pleasure to welcome you to the difficult to treat TB clinic. Today we are going to present a difficult case from our school. So it is a 25-year-old student, resident of with no addiction history, with no history of any other comorbidities, with negative viral mark, BMI of 768 kilograms. The weight is presented to us.
Echo, Nita, echo हो रही है, sound echo.
जी sir, we are just looking into it. Abhishek, just give us a minute.
Thank you.
तुम्हारा तो
We are continuing with our case. So this 25-year-old unmarried male student, resident of New Delhi, with no known comorbidities, no addiction history, with all the viral markers negative, with a BMI of 27.68 kg per meter square, with a weight of 80 kg presented to our OPD. So we will first look at a brief past TB history. So initially the patient was diagnosed first time as a case of pre-XDR pulmonary TB in March 2020 with an LPA suggestive of resistance to rifampicin, isoniazids, and levofloxacin. So this patient was started on an all-oral longer regimen for which the patient took the treatment for 2 months and then he was asked to follow up. The following regimen has been proposed at that time, with including bedaquiline, moxifloxacin, dinazolate, cycloserine, and clofazimine as per his weight band. Then next time the patient presented around 1 year after the stopping the treatment, with all the constitutional symptoms of cough, expectoration, fever, and unintentional weight loss. The patient then evaluated for same and was diagnosed as a case of pre-XDR TB. The time the patient was diagnosed again in 2024, his weight was 72 kg and the BMI of 24.91 kg. And the treatment was started as per the weight band given in the PMDT guidelines 2021. So started on drugs including bedaquiline, moxiflox, dinazolate, cycloserine, clofazimine, and delamide was also added to this regimen. His sputum reports in CBNAT is suggestive of a MTB reaction is there with a high load with rifampicin resistance, and LPA was suggestive of rifampicin, isoniazid, and levoflox resistance. So the patient was started on delamide also. Then the MGIT culture came along with the liquid culture DST for this patient, which give our confirmation to bedaquiline, delamide, and dinazolate. All were susceptible. Then the patient was followed up clinically, as well as the sputum was given by the patient on regular basis as per the guidelines. So at 4th month, the patient's smear and cultures were negative, but 5th month onward, the patient's sputum came out to be positive, 6th, 7th, and so on. The cultures came repeatedly positive. And the DST has been shown for all the cultures in the slide itself, which shows no additional resistance in the pattern. Only ethionamide is resistant, which is resistant in the baseline DST also. Next, the patient was continued till 12 months of treatment. Then, while the patient is continued, patient showed a good slight radiological and clinical response to our treatment. Next. So the patient showed response to the treatment. The initial treatment initiation X-ray is given in the left corner, and over the period of time in that treatment regimen, the following X-rays has been shown. Furthermore, the patient also showed a clinical response as fever was subsided and there was a weight gain of 8 kgs. The compliance to the treatment was very good. And betaquilin as a 6-month culture and 8-month culture were positive. It continued till the 12 months and delamanid was stopped at 6 months. But in view of repeated positive follow-up MGIT cultures, the patient was declared as a treatment failure after the 15 months of treatment on the basis of 12-month culture report which came out in the fall. Now, the question which arises to us is what could be the possible cause that led to a treatment failure in this patient, as the patient has taken appropriate drug and doses were according to the weight band. The compliance was very good, and the follow-up is also as per the guidelines. The patient did follow. So the question arises to us. So we looked into the case and answer these questions: whether the patient has acquired some drug resistance, whether the compliance, which was checked at every follow-up visit of the patients. And the third thing, after checking all this, came to us is the malabsorption. Is the oral drug is having some issues with the absorption, if the levels are subtherapeutic or what. So then we proceeded with that, and subsequently we planned a TDM for the patient. The TDM was planned with the second-line drugs, along with some other investigation was also done. So in November 25, at 14 months of his treatment, the patient was planned for did a TDM on moxifloxacin and linezolid, as bedaquiline was stopped in September 25 and delamanid was stopped at the 6-month treatment regimen. So 2 drugs were available for us to do a TDM. So moxiflox and linezolid were chosen to do a baseline TDM for this patient. So 2 hour levels we got a subtherapeutic levels for this patient for 2 hours. The TDM. Now we advise the patient to take a gastroenterologist opinion for this regarding any malabsorption, and was advised to go under the micron and other investigation. Patient did that. The folic acid levels were found to be low. Vitamin B12, vitamin D3 levels were also found to be very low in this patient. A USG whole abdomen was also advised by the gastroenterology department, and there was no abnormality as such detected in that ultrasound. Then the patient was then we did a pre-treatment again we did a pre-treatment evaluation for this patient and planned this patient to start on an injectable based individualized treatment regimen as decided by our DRTB committee. So 12-month culture was taken as a baseline DST for this patient, and the patient was started on an individualized regimen in January 2026. This is the DST shown in the right corner, which is suggestive of his ethionamide and bedaquiline resistance. These are the investigation we did pre-treatment for this patient in January 26 with the hemoglobin of 12.1, platelet count of 4,47,000 with a normal left range. Renal function was also within the normal limits. Then electrolytes and again puritonatrimetry for his ENT evaluation, puritonatrimetry bilateral hearing safe limits. Then ITR was planned. An ITR was planned based on some oral and injectable drugs. So in the oral regimen, we included bedaquiline and loaded the patient again with 400 mg per day. Then delamanid was also chosen, and PAS also taken in this regimen. Along with injectable drugs, we shifted linezolid to an injectable regimen. We added amikacin, we added meropenem and moxiflox as per the as per our TDM reports, as linezolid and moxi are showing low levels in the oral regimen. However, later the tablet bedaquiline has to be stopped in starting of the February, as the DST reports came out late in the January suggesting of resistance. And injection moxiflox has to be changed to oral after 2 days, as the patient was not tolerating the IV dose. Then again a TDM was planned after 15 days of starting the regimen on the patient when they started on an injectable ITR. So again, we found that moxiflox, however, has been improved. Levels of the moxiflox, however, has been linezolid. Now, in this regimen also, in IV drug form, is also showing subtherapeutic level when we did an TDM on 2, 4, and 6 hours of drug administration. Bedaquiline, before stopping, we did that in the loading phase only. So bedaquiline showed therapeutic levels, and delamine also showed significant, they are at acceptable therapeutic levels in this TDM report. Next, we did a follow-up for this patient with sputum smears and cultures, which are found to be negative on the first. Sorry for the mistake, but it is the first block is first month culture, which is negative. Second month culture given in March is also negative. Third month culture, fourth month, and fifth month, which is the latest culture, is also negative. The follow-up radiology of this patient has shown some improvement. Right-hand corner is the treatment initiation X-ray of the patient when the patient was started on an ITR, and the left side you are seeing the at present the latest X-ray of July 2026. The patient also the patient has showed a favorable clinical response to the regimen with a weight gain of around 10 kgs. With a BMI now the patient is having 31.14 kg per meter square. But the patient developed tinnitus in August, and the pure tone endometry was done for this, which is suggestive of mild sensorineural hearing loss. So injection amikacin has to be stopped in view of above adverse event. And at the time of stopping amikacin, we repeated the TDM for this patient again in this one only, and we found that linezolid levels are persistently at therapeutic level when we done the sampling at 2, 4, and 6 hours of drug administration. Moxiflox and delaminate levels are in acceptable range of the acceptable therapeutic range. Next. At present, the patient is now continued in the following regimen with oral drug comprising of moxiflox, delaminate, PAS, and injectable, which we are continuing with injection linezolid 600 mg and meropenem 1 gram IV every 8 hours. Looking at this, 3 questions arise to us during and now at present at the treatment. First question which arises to us is how to decide the patient on an individualized regimen. How to decide such patient to how can we make an individualized regimen for this patient? Second question that arises to us is when to suspect for any malabsorption. If the patient is showing some clinical and radiological response, then when to suspect for malabsorption. And the third question which arises to us is then how long, if we are making an injectable regimen, how long the injectable drugs to be continued for the patients.
Thank you, Abhishek. Excellent presentation and very well worked up case. So now we open this case for discussion for any questions. Dr.
Nita, my only one query is there. So when patient took initially for 2 months, then the patient was lost to follow-up. So did anybody try to contact the patient?
Yes, sir. All the patients are contacted and retrieved, and all efforts are made to retrieve the patient. We are also joined by the district TB officer of Malvinagar who has been managing this case, and maybe she can tell us better. But yes, she has informed us that all the efforts were made to retrieve the patient.
Okay, thank you, thank you.
Hello.
Yes, sir. Yes, Dr. Ankur.
Ma'am, my question is: patient gained 8 kg weight during the second course, which was regular, but the cultures were coming positive. and when the treatment was changed, patient gained 10 kg weight. So is terming this malabsorption is the correct term because there were no symptoms reported like steatorrhea or nausea, vomiting. Patient this time was taking PAS, amoxiclav, and still not having gastrointestinal because it is not in the history and not so it is not reported. So the term malabsorption uh, is accurate in this situation. So your opinion on it.
Listen,
Yes, Dr. Ankur, very well pointed out question, whether we can call this patient as a malabsorption or was it the failure was due to the bedoprine resistance. So if we look into the case, first time the patient was lost to follow-up after 2 months of treatment. Second time they started on the same regimen, all over longer regimen. And on a prophylactical basis, we have included eliminate also because patient was case of pre-XDR. If we look into we cannot label it as completely malabsorption, but if we correlate all the findings, then patient already had exposure to bedoprine in the past also. And low level of moxifloxacin was also resistant, where we gave high dose moxifloxacin, which was sensitive in this patient. But if we correlate the levels of moxifloxacin and linezolid in the patient, they were low. And patient later on also developed bedoprine resistance at 12 months of age. So is it like the acquired bedoprine resistance? So the acquired bedoprine resistance in this case could be prior exposure also and could be the poor regimen which is accompanied with bedoprine. So poor, why will I say poor? Because moxifloxacin was in subtherapeutic doses, linezolid was in subtherapeutic doses. If bedaquiline is acquiring a resistance, there is a chances of having a cross resistance to clofazimine also. So patient was actually left with only cycloserine, which could be sensitive or which could have have a good blood levels. We do not have the TDM for cycloserine at present. So maybe the failure could be due to bedaquiline acquired resistance, and which is further supported by the low levels of the drug in the TDM on therapeutic drug.
one thing is appreciable for this case is that consistently we have all the cultures available. Every month the cultures were done whenever patient was on therapy. And one of the rare patients where we have the therapeutic drug monitoring done 3 times. In all the 3 different regimes it was done. So that way this patient was very lucky to get all the possible care that he can get. So are there any questions on history?
This patient was definitely showing initial improvement. Patient have shown to the treatment we gave during the second course. There was a weight gain, there was a radiological improvement, there was clinical improvement in the patient. In the later half of the treatment, patient went into failure.
Somebody wanted to see the X-ray. Dr. Lalit Kumar, you have any question? I would request Dr. Chopra sir for his comments for this case.
Thank you, Dr. Neeta. This case gives us few learnings also. As Dr. Bhardwaj pointed out, after 2 months, patient left to follow up. So this is very important, and this is usual history whenever we present in our state cases also. That patient, after starting the treatment, when he gets some improvement, patient usually leaves treatment. Many cases. Second important point is compliance. So when we say a patient was compliant to treatment many times, if treatment is every dose is not observed, we cannot be sure that patient was compliant to the treatment. Either patient needs to be admitted, or there may be surprise checking at home whether patient is taking treatment or not. Avoiding LTFU is very important at the district level and the field station. For that initial counseling is very important. Patient should be told that this is the last regimen available. Drugs are very costly. Drugs are toxic, but you should take treatment so that you are saved of this problem. So that is first and foremost point, rightly pointed out by Bhardwaj sir. Second important point in this management of this case is importance of TDM. So TDM we have found for major drugs, therapeutic drug levels were low, but it was done after when patients started failing to the treatment. So we can learn that if facilities exist in such cases, therapeutic drug monitoring should be done at early stages to detect subtherapeutic level and to increase its dose or to change the drug so that patient improves and drugs are not wasted. The patient simultaneously develops side effects also. Third learning from this is patient when started on treatment, he was 70 plus, 80 or more than 80, and during treatment also gained treatment. But when we start the treatment, our weight band show maximum weight band is our 70 kg. So after 70 kg, weight was 80 or 90 kg, we should think of that dose should be increased in such patient, and that could be that high weight could be one of the reasons of subtherapeutic drugs availability, because according to the weight, we are giving drugs only for the 70 kg weight. So another point important is that because of such therapeutic level or high weight, it remains that low dose has been given as per the weight, and it can lead to failure as well as it can lead to the acquired drug resistance also. So these are the few learnings from this case which we can follow in managing such cases in future. Thank you.
Yeah, thank you so much, sir. Very important messages that you have given. You said that we need to see the weight of the patient, like after 70 kgs, yes, we have put the doses. So there's also a question whether the surgery should have been considered.
Yes, this is another. In such cases which are failing, surgery should be taken if the disease is localized, as in this case, disease localized only to the upper zones. And if patient is responding or patient's general condition is fit for the surgery, we should take opinion of surgeon also. That's very important.
Thank you. Thank you so much, sir. Are there any questions from the house?
So just to add on to the comment of Dr. Chopra, these cavity lesions, they do have a different absorption rate of drugs also. So yes, surgery should be considered in such cases because that can lead to subtherapeutic levels of the drug and can also cause drug resistance and, like in this case, acquired resistance to the bedaquiline. And bedaquiline is known for differing drug levels at a different cavity.
Thank you. Thank you, Dr. Sunil. Dr. Salim Bhargav, sir, would you like to add anything?
Yeah. So, am I audible well?
Yes, sir. Yes, sir.
Oh, that's great. So, it was a good workup for the patient. I think it was it was managed well with the patient. But there are a few questions. What I will be talking in next 2-3 minutes, it will include some philosophy, some policies, what national level, at what mass level we can do, individualized. Abhishek, the team has done so well, and we have been trying well to do that. There are some questions which have been coming up, which Dr. Chopra has already discussed, and a few participants are also talking about that. Importance of regular follow-up of patients whom we are suspecting and in whom there is a possibility of drug resistance. We have been trying that. Can we anticipate in advance where are the patients who are going to be lost to follow-up? Or another thing is, in patients who are already having pre-XDR TB, why not next day they should get a call? I remember one story in America when drug resistance was developing there. What did they do? उन्होंने जेल जैसे prisons बना के और वहां रोक के और उनको पकड़ के एक बार ठीक किया. अदरवाइज अमेरिका में HIV और इसके साथ मिलके, मेरे दोस्त हैं, उन्होंने एक बार बात करी थी. So we have to think of such time. As I told you, I will be talking of some policies and some philosophies. One of the participants talked about surgical intervention. Oh my God, yes. This should be considered quite early. And because it was looking at thick wall cavity, the drug penetration may not be that good. And already we are struggling with multiple resistance. Should we think of surgical intervention? I think yes. And the drugs should be continued, and along with that, if possible, there must be some very big centers who can take it up, and we should go for some surgical interventions. There are some things like that, other non-pharmacological interventions. The pre-assessment is very, very important. Looking for blood sugar, no doubt. HIV, perfectly fine. Everything has been done, I know that. But it is very, very important. We should not miss it. And then apart from it, I tell you what he was asking, what is the reason for development? Abhishek has asked, raise one. The first question is, what is the cause? In fact, we should always think of that. And we should take into the consideration sedentary lifestyles, not doing any regular yoga practices. Persons like this may go with such type of things, add-on therapies, non-pharmacological therapies. Controlling diabetes, even if there is slightly hyperglycemia, it should be taken care, because you never know which are patients who are going to land into drug resistance. Then looking to the LFTs, we have been watching, I do very regularly liver function test in almost all TB patients. And you will find that in vegetarians, the total proteins are slightly on the lesser side, what I have found in good number of patients in whom we go for it. And hypoglobulinemia and other things may be there. So at what time we should replace them, and at what time we should take care of them. So initial assessment is very important. Malabsorption, I don't know, malabsorption not only includes acetoria, there may be malabsorption of some vitamins. B12 was slightly deficient, vitamin D. So we are using not high dose, as they've been writing here. We have been using vitamin D and vitamin C. I remember that our seniors used to say, don't write unnecessary medications, otherwise they will skip the true anti-TB drugs. But no, I think we should take care of vitamin D, vitamin C. These are 2-3 vitamins at least, which take care of body immunity. I'm a general physician also, MD medicine also. So I take care of almost all the things should be taken care, particularly when you are struggling with such type of patients. Certainly no doubt about, I'm not sure vitamin C kills TB bacilli or no. There's somebody, Lalit Kumar is asking that. But at least it gives body immunity. It enhances your body immunity. We have used in COVID very right and left. COVID, we have used it. So vitamin C, if there are no issues, it's not very costly also. So we can check it and we can use it. Other things, we should always think about drug resistance, causes and prevention. Why it is there, why it is there. There are, I think that the team was struggling with a lot of drug resistance. What is the problem? And in fact, the team which has treated such type of management, it's not possible at other levels. I'm sure it's not possible at all. Even at medical colleges, at other centers, you cannot go for the therapeutic levels, monitoring and other things cannot be done so easily. So do we need to revise strategies so that we can have some centers which are specialized for handling such type of patients? That includes therapeutic levels monitoring, and then to handle it. Even then it was done, linezolid levels were slightly on the lesser side. What is the cause? Can you increase the dose beyond that level also? So the program has clear-cut guidelines. Don't go beyond this level. Otherwise, the platelets may drop down. So what to do then? So not sure about this. So as I told you, we have to think of policies, at least 8 or 10 centers in the country where we can handle. We will have to send them patients blindly. We have no options for treating at smaller centers. So you need to have specialized centers. And I've been talking to Dr. Rupak Singla for the last 2-3 years. This was a complex case, I know. But for other drug resistance cases also, I know that one application is already there for ICMR, because nowadays it is the time of artificial intelligence applications. So if you put the condition, can application, AI and some expert answer, please take care of this, go through this line? Because I know more than 5,000 doctors or more than that might be, yeah, rightly said, peripheral problem is even worse. Follow-up, timely sputum, even monthly weight checkup is not done. Very right, very right. This is, you are talking of an individual case with drug resistance. I am talking of primary TB management also. They are vomiting, but I'm not sure who is taking care of it. So can we come up already? I know Dr. Rupak Singla will inform me again that ICMR has come up with an application where you can put your patient's data and you can get the responses very quickly. So we need to change our gear also to enhance our strategies for diagnosing, anticipating and handling drug resistance. In a single case, in a place like yours is possible, but in periphery, we cannot manage such type of things. So the surgical intervention has to be talked very frequently, particularly in such type of cases. Artificial intelligence, I know DDG TB madam is there, can we think of such things, or are there any plans to come out with such type of things, or if they are there, how everybody can use it? So this is from my end. Dr. Neeta, thank you very much for informing me and involving me in such great discussion. Thank you again. Yeah.
Thank you, sir. Really nice comments and a lot to take from your comments, and they are very important comments for us. As you said that yes, we need some specialized centers beyond nodal DRTB centers to take care of such patients, because this patient, as I said, was very lucky because we could get injection Moxie, injection Linzo, injection Mirapinam for this patient. We could, arrange it at institute level, but if the other centers may not be able to arrange the injectable drugs. So injectable drugs are still an issue at most of the centers. So are there any comments or questions?
There are some questions related to therapeutic drug.
Dr. Devika is our head of the department biochemistry, and she has established the therapeutic drug monitoring unit at NITRD, and we are doing it for both first and second line drugs. Yeah. So welcome, Dr. Devika. And
ma'am, the first question is from the case itself. Despite of giving IV drugs to the patient, the levels are still low for lineage. So what could be the reason?
So maybe we ask the dose is not appropriate. So if we increase the dose, then we can check it again.
Yeah. So
one of the main reasons, because in the patient, like IV patients, compliance will be there, bile absorption has already been booked out. So this could be the main reason.
Okay, because the weight is on the higher end. Yes. We were already thinking to increase but the patient at the same time is also showing good clinical
response. So we need to correlate both the things.
Ma'am, another question for you is how did we decide reference is range of therapeutic drug levels, because different studies have shown different levels. So how have you centralized?
Yeah, we check same way we check the literature. The Cmax has to be checked in all the literature. So C minimum is the trough level before the drug is administered, and Cmax usually it is the same. Then we check it what is given in the Indian population. So the literature everywhere is decided, but it is given that the range for the linezolid is 10 to 20 microgram per ml. So we have taken this. Other way is to check it to establish the own lab mean, but then for that we should have done this test in at least 2,000 patients. So we started this facility just 2 years ago. So till now we have not completed so many samples. So we are also just taking the range what is available in the literature. Thank you, ma'am.
Madam, I have a question related to this therapeutic levels. Yes, you are doing at your center. That's great for last 2 years. The question is when to do it, how to do it, how to interpret it. It's not that easy. One thing, there are not many centers, government centers who are doing it. So suppose if it is out of Delhi or at some places, where should we contact? Are there any systems by which we can send samples to your system and you will do it something? So that is, I told you as that there are something has to be done at national level, at government level, some policies has to be decided. So when to ask for, how frequently to ask for, and certainly after few years, you will able to tell us whether they are really cost effective or not, whether to do this exercise or not, because it's very costly thing. I understand that it's not that simple. So we should again think on these lines also. You are a great scientist and you have been doing it and you are supporting our patients. That good. And we are thankful to you. But on a national level, how can we apply this knowledge, information, when, how? Please.
At the national level, say, like every state capital should have one TDM center, so that the patients can go, like they need not come to Delhi for everything. The states should be self-sufficient, and then a TDM center should be there, which should have the proper equipments and the manpower to do this assay. Now, for doing this assay, of course, we need a proper lab. A TDM lab is different from any other biochemistry or pathology lab. So, a proper lab with the supporting equipment should be there. And then, of course, we have a Shimadzu HPLC system, and that's a smaller machine. The bigger one, LCMS, is there, with which we can do much more. Maybe all those which we are not able to do are possible on LCMS. So this is a state policy. I think government has to take an initiative to establish such centers everywhere in India. And for us, like because ours is a small, like we just started it as a pilot, if it is required also or not. So we do the test only for our institute patients. It's difficult for us to take care of other patients which are not registered in our institute.
So just to add on to that, we have certain policies when to send the patient for TDM level, and yes, of course, after permission on PAP, because we have a limited facility. But yes, it's a big help to the institute and to managing our patients. And and culture DST, and they're coming up sensitive. But there's a poor clinical response in this patient in terms of clinical response and radiological improvement also after ruling out resistance. So these are the patients to whom we are subjecting to TDM, and many a times, most of the time, is helping us.
We have seen many cases, many cases when the dose is increased, the patient responds very well, starts gaining the weight and the lesion subsides. So like it's a good feeling, like just by increasing the dose, the patient gets cured. Before moving to DRTP, that's something achievable.
Great, thank you.
Are there any questions? Dr. Singla, would you like to add anything to this case?
Yes, first of all, I'd like to congratulate the NITRD team. They worked on the case very, very well. And Abhishek for presenting it so well. This is a very interesting case in the sense that it is raising several concerns, and as well as it is focusing on several aspects of the DRV management in the country. Like, for example, first thing is, in this case, the DST result came late and the bedaquiline was already started. And patient was on bedaquiline containing regimen for almost 14-15 months. And then it was, in the new regime was made, we did not have any bedaquiline sensitivity with us. And it was started, and then the report came 1 to 2 months after the starting of this. So they have to stop the bedaquiline. So what is being seen in the field that even with the liquid culture, the report of bedaquiline, or for that matter, for any drug, the DST report is taking 2 months or 3 months, sometimes 4 months. Sometimes there are delays at the laboratory level, and sometimes the laboratory put the report on the Nikshay. Still, the treating physician, the treating DT or MO, they don't see the report and act on this. So we have to be fast in this case, and ideally we should be having the report within, say, 1.5 to 2 months, and action should be taken accordingly. Another very important thing in this case is that patient received the same drugs from September 24 to December 25, same regime, same drugs, and remained culture positive. You see, whenever the basic dictum is, whenever a person is on a particular regime and is compliant to the regime, and at 4 months culture is positive. So this is a flag point that you must send culture in DST. And once the DST report comes, you need to have a review of the case, whether to continue with the same drug or make individualized treatment regime. And at 6 months, if the culture report is positive, which usually comes by 7th or 8th month, definitely you have to declare the patient as failure to treatment, and you have to look for another regime. But in this case, for 15 months, patient was continued on the same regime despite being positive in all the culture reports. So we have to act early. Otherwise, like in this case, also the one of the reason of developing bedaquiline resistance could have been that he was given bedaquiline for 1 year, even when the cultures were positive. So that we have to prevent the augmentation of resistance to the good drugs. Third important thing is regarding the TDM. It is raising certain very interesting aspects. First of all, before I talk about that, I must congratulate Dr. Devika, who started the TDM not only to the first line drugs, but also the line drugs. And I'm sure she must have faced a lot of challenges, and from clinician also that we were after her, they started early, you started early, we need the reports. But she took her own time, she established the team laboratory, she standardized the procedure, and then only she started giving the reports. But it's very good that she could start this facility in our institute. You see, in January 26, the ITR was started. In this case, the individualized treatment regime, which consisted of moxifloxacin, initially injectable, then oral, delaminate, pass, injection linezolid, injection amikacin, and injection meropenem. Just before starting this, a TDM was done, which showed the level of moxi to be low and level of linezolid also to be low. And once this regime had been started, which had 3 injections, including amikacin, linezolid, and meropenem, again it was found, and patient was on oral moxifloxacin. So this patient was taking oral moxifloxacin before starting ITR, and within 2-3 weeks of starting ITR, but it was found that now moxifloxacin levels were within normal range. So which were low about 2-3 weeks before, and now having the same dosage, the levels were normal. So ideally in this case, we have to check it again that what is the reason, whether they were really low earlier or not, and whether they are really normal or not. Second thing about the TDM in this case was that at the start of ITR, the TDM with injectable linezolid was found to be low at 2 weeks of treatment. So that could have been an alarm that after starting injection also it is low. So we need to repeat in such cases to really observe whether the injectable linezolid is raising the levels or not to the desired level. Earlier, I remember when we did not have the facility of TDM for the second line drugs, what we used to do was that, okay, first line drugs, the levels are low, patient is failing to treatment. We will start the injectable second line drugs with a belief that by converting to injectables, now the levels must have achieved. But here we have a scenario where we have the facility for second line drugs TDM, which is very, very good. So we should make use of it. And you know, even after 8 months of injectable linezolid, the levels were still low. So that means during this period of 7-8 months, patient was on inadequate dosage of linezolid. So that again caused that whenever the level is low, please repeat maybe in 2-3 weeks. Although I agree that performing TDM levels repeatedly is again a challenge to the institute, challenge to the laboratory. So many patients are waiting in queue to get the TDM done in a tertiary referral center. But still, we should ensure that within 1 or 2 months, whenever we find the levels are low despite injectables, we need to repeat it and augment the dose if it is required. Another interesting thing in this case is if you see the delaminate. At 2 hours, the delaminate levels were low, but when they were done at 4 hours and 6 hours, they improved and they became normal. So this is called delayed absorption of the drugs. In case we do not do at 4 or 6 hours, we may feel that the levels at 2 hours levels are low, and we need to take action of switching to the other drug, or if possible, switching to the injectables and all this. So ideally speaking, if possible, we should do not only at 2 hours, another sample either at 4 hours or 6 hours or both. Now again, it's a luxury to ask for the 3 samples at 3 different times in a patient. But this case is an example where by doing the levels at 2, 4, and 6, we could demonstrate that there was a slow absorption of the drug, and by 4 and 6 our sample, we found the levels were normal. But I repeat that this is a challenge in these field conditions. Now coming to the final degree and the duration of imipenem. That is again very important that we start the meropenem or imipenem, whatever it is, and how long to give it. And you know, we all know that the meropenem has its own logistic challenges. The cost is very, very high. We need to insert a PICC line, which has its own cost. Not only the cost, you see, facility for having trained people to insert this is very, very limited. This I'm realizing because sometimes we get people from nearby states that we do not have any person who can insert PICC line. I don't know why it is there, but it is there. Even in Delhi, we find very few doctors who are trained to put the PICC line. So that is another challenge. And usually after 2-3 months, we have to change the PICC line. So in this case, what I do is that I start the regime containing meropenem or imipenem. Usual target is 6 months, maybe up to 9 months. And at that time, patient is responding like in this case, all the cultures were negative, the X-ray was static. So if possible, technically, we need to stop the imipenem. The only indication of continuing with the PNM is if you start the PNM, you're left with only 2 drugs or 3 drugs in the continuation phase, which may not be enough. When you go back to this case, now patient has developed the hearing loss, so definitely mitocin has to be stopped. If you stop mitocin, we are left with meropenem, injection, linezolid, moxifloxacin, delamanid, and PAS. So here, if you stop meropenem, we still have 4 drugs with us: injection, linezolid, moxifloxacin, delamanid, and PAS, which forms a fairly good continuation phase. Of course, we'll have to increase the dose of linezolid and prove by the TDM that now we are able to achieve. But if you include injection linezolid, we have 4 good drugs on which we can rely upon. So there is a case that we can consider stopping meropenem in this case. And regarding the surgical, you see, yes, surgery should be considered in these cases where they have cavity lesions and are not responding and failing to treatment. Here the challenge comes is, as we all know, in NITRD, we have been doing surgery for 50, 60 years. Our surgeons and anesthesiologists, they prefer when they take up the patient to the OT table, preferably patient should be on likely to be effective regime for at least 2 to 3 months. They prefer that patient should be sputum negative when they are taking up for the operation, which sometimes or most of the time is not possible. But at least a regime which is likely to be effective, patient should be on that for 2-3 months before the patient is taken up for surgery. Like in this case, after starting the ITR, patient became culture negative at every month. So that is the time, if required. But by that time, if you see the X-rays, there is right upper lobe fibrotic collapse. So the cavities have disappeared, they have collapsed, and patient is having right upper lobe fibrotic collapse. Some people may like to go for it to prevent the relapses. That is one theory which is acceptable. But once the cavities are gone and there is a fibrotic collapse, sometimes patient refuse to go for it. And sometimes the treating doctors, they don't feel comfortable, they don't feel the need to go for surgery. Good thing is that patient improved clinically, radiologically became static, patient gained weight. And as somebody said, once the patient is gaining weight, we need to have a real look at the dosages being given. We need to do the TDM again to see whether the increased weight, whether our drugs are reaching the levels or not. And regarding the malabsorption, it is again a challenge in these. We have been doing TDM since 2016 in our institute. And earlier we were very aggressive in investigating for the cause of malabsorption. Once we have this kind of scenario where the levels are low, we used to think of malabsorption. And of course, using this, the fecal fat xylose test, we used to refer the case to AIMS, gastroenterology. And I remember Dr. Abhijay is there. I used to work with him. And many cases we did the gastric biopsy just to rule out celiac disease or other causes of malabsorption. In none of my cases, I found the gastric biopsy to be abnormal. So it becomes difficult in these cases to look what is the cause of malabsorption, why patient is not absorbing the drugs. Common causes like diabetes, the HIV, the other immunodeficiency syndromes, they could be there, but we are not able to find in most of our cases. So that is one thing which I have never been able to explain. So that also we need to know and we need to act accordingly. So that's what I want to say. And this case is interesting and is informing us about so many aspects of the DRTB management, the challenges, their solutions. And of course, I request the DDGTB man, Dr. Shobini, that as on every forum I have been insisting, there is a need for TDM, at least one in every state of this big country. At least one in every state of the big country. So that such cases can be managed at the state level. Thank you.
So I have a small query when you said that we can, yes, 9 months of injectables we have already given to the patient, we can stop meropenem. In this case, yes, malabsorption, it doesn't look like there was some issue with absorption, but yes, with better availability of drugs and injectable. We have limitation with meropenem, that it is only available in injectable form because we haven't tried the oral preparation yet. But sir, in cases of linezolid, has a good availability both in terms of oral preparation and in terms of IV preparation. So do we really need to continue IV linezolid? Yeah, we will be going to increase the doses, definitely, but it has 100% oral viability.
Yes, I think very good question, Dr. Roj, you have raised. You see, in this case, the issue is before starting the ITR, the linezolid levels were low. After 2 weeks of ITR with injection of 600 grams, the levels were low. At the 8 months of ITR of linezolid, the levels are low. So before we think of the oral, I think we need to step up the dose of injectable linezolid. Maybe we can try up to 900. And once we find that, yes, now we are achieving the levels, then we can think of shifting to the oral. Although as a treating physician in this regime, now of 4 drugs, injection, linezolid, moxifloxacin, delamidine, and PAS, I will be thinking twice before shifting to the oral. But as you said, we can take a chance, first increase the dose of injection, linezolid dose, prove that the blood levels are being achieved, and then we can take a chance to shift to the oral and monitor with the TDM levels again, whether we are still having the acceptable levels or not.
Right, so thank you, sir.
Thank you.
Thank you, Dr. Singla. Are there any questions?
मैम डॉक्टर विशाल बोल रहा हूँ लोकनायक से
जी सर
मैम दिस क्वेश्चन इज टू सर डॉक्टर सिंगला कि जब तक till we have a therapeutic drug monitoring in place, what to do at peripheral levels or at district level in the patient we are seeing that the patient is compliant and resistance is ruled out and the patient is not responding.
Yes, you see
what is
this
the carry-out message for me?
Yeah. So Dr. Vishal, जो आपने क्वेश्चन किया है, this we have been facing for years. We did not have TDM before, say, 2000, maybe 6, 7, 8 years down the line. So what we used to do was that patient is not responding and is showing sensitive every time. First of all, we used to declare them as treatment failed. Treatment failed means they have not responded to the current combination of drugs. We will make an ITR, and in the ITR, I also used to do was try to have maximum injection as much as possible. Like in this case, the regimen chosen was injection meropenem, injection linezolid, injection moxifloxacin in this case, and the fourth was the fourth one was amikacin. So we have 4 injectable drugs and rest 2, 3 of oral drugs. So in the field conditions, there is no option other than this, and which is a great challenge. Not in terms of the cost of course, inserting a PICC line, then arranging injection linezolid, moxifloxacin, they are all expensive. If you see, compared to the oral drug, the cost is several times higher once we give that injection level, but there is no other way. And now we are wiser that after shifting to injectable, at least we are able to measure the level and show that now patient is achieving the levels. But by following this policy, I can tell you many patients we have cured by shifting to the injection containing regimen without the TDM level with us.
Thank you, sir.
Many doctors in the group which I can say that they have sent the cases to our institute. We followed this policy and their patient improved clinically, radiologically, and microbiologically. I hope I answered Dr. Vishal your query.
Yes, sir. Thank you, sir.
Thank you.
Dr. Neeta, can I ask one question here?
Sure, sir.
Yeah. So I'm trying to raise a thing which is slightly debatable and disputable. We are talking of resistance. We are checking the therapeutic levels. But have we ever tried for bioavailability? This is, I know the madam from biochemistry will understand what I'm saying. I'm not a pharmacist, not from pharmacology, but bioavailability is something I remember one thing. Some years back, there are 10, 20 companies who were making rifampicin. But the bioavailability was different for different types of companies. So if the bioavailability is poor with a particular brand, then the therapeutic level will certainly be lesser on that side. So at CTD level or at some level, somebody is looking after bioavailability of drugs which are being used on a mass scale? I don't know who has to answer it, but I'm raising a question because we have been facing the problem of drug resistance. So, Dr. Rupak, is
Yes,
it
yes.
really to talk about
Yeah.
bioavailability?
I have some experience on this. You see, conventionally, it is known that whenever you combine INH with rifampicin, the bioavailability is likely to be effective. So they say you must buy this combination from a company which has proven track record of having good GMP practice, so that the bioavailability is proved. And now you see that was the reason for several years we did not shift to FDCs. FDC, they have all the 4 drugs. Although there was a lot of pressure from the WHO side that the whole world is using FDC, why not India? But till our Indian government, the CTD, was sure that they are able to prove the acceptable bioavailability, they did not go for it. And even after that, now what they do is they check the batches for the bioavailability whenever before putting it to the feed. So in the batch in different states, they are tested for the bioavailability, and then only it is being used in the country. This part what we raised for the PGs and for the DTOs, that there is something called bioavailability, and we should be aware of this. And nowadays, you see, in the practice, we are seeing that most of the doctors are using this 4 drug combination, like the program is using. But the program is having a good check on the bioavailability, while the drugs which are available in the market. Now, any small company is making this combination of 4 salts. So please be careful before you write or before you buy this combination of 4 drugs, so that sometime we are likely to miss the bioavailability issue, and the levels achieved by these combinations may not be adequate. Thank you.
Thank you, Dr. Singha. Do you have any question? So if they are not, there are not any questions, I suppose. If there are any questions, we can still take them. So I would just like to summarize the discussion that we had. Today we discussed a case who has taken DRTB treatment twice and was failing to do treatment. And then the patient was put on ITR, and in ITR we introduced 4 injectable drugs and 3 oral drugs, to which patient is responding well. But the patient had some ADRs, due to which some injections had to be stopped. And this case was appreciated because it's been worked out very well. Patient was able to get all the injectable drugs. The therapeutic drug monitoring was done thrice for this patient. So that way, this patient was very lucky that he got all the facilities. But still, what our experts have very rightly discussed, that this patient at the onset should have been handled with regular follow-up. As Dr. Bharadwaj sir said, that the moment the patient interrupted for the first time during his first treatment, he should have been there should have been strict monitoring. He should have been retrieved and he should have been put on treatment, because he took treatment for 2 months and then he disappeared. So it should be a red flag, and the concerned DTOs should really look into it. The second important point that was raised was that we could have considered surgery at some point of time. So again, that is something that we all as district TB officers should keep in mind, that there is an option for surgery, and if possible, it should be offered to the patient. When we have to look for other causes of resistance, why it is there, there should be management of comorbidities. If there are any malabsorption, that should be taken care of. If possible, add some vitamins like vitamin D and C. So all that should have been done. And Dr. Salil has very rightly raised some policy questions, that something that Central TB Division has to look into, that is having therapeutic drug monitoring facility at least at state level. Every state should be having these facilities. There should be availability of injectable drugs to the patient. Any patient who requires it, there should be a mechanism through which the injectable drugs should be made available, and especially the PIC line and experts to put the PIC line. because without quicklime, giving injectable drugs for a long duration is difficult. There should be center of excellences where, above the nodal DRTB center, such patients can be referred to and can be taken care of. And facilities of surgery should be linked. Wherever there are surgeries, such centers should be linked to the nodal DRTB center. So I think that was the first. Did I miss anything?
No, but just to add on to that, we are saying, even I myself have said the surgery could have been opted and an option for such patient. But do we really have enough institute in the government system who perform thoracic surgery? I think the number is very less. The centers are very few who are doing thoracic surgeries, and private, most of our patients are not able to afford surgery in private sector. So that's a real challenge. The same way we have TDM performing TDM challenge, the same way we have challenges of having a quick line insertion. We at NITRD, being sitting at the center of the country, we do face challenges in having quick line insertion. So these are the real challenges for the periphery, and surgery is a big challenge. Not very many institutes are performing thoracic surgeries for such patients.
Yeah. So thank you so much. Thank you, Dr. Salil, Dr. Rupak Singla, and the experts who are with me here today, and all the people who have joined. Now I request Dr. Bharat to
So thank you, Nita. So I want to add to Dr. Singla what he coined, the facility for therapeutic drug monitoring. So I as on I am following this clinic right from 2021. So right from 2022, 23, 24, 25, now 26. This was a demand in wherever such type of case was presented, there was a demand of therapeutic drug monitoring. So मैंने थोड़ा सा एक बात बोलनी है नीता, अगर कोई हमने एनालाइजर खरीदना है मेडिकल कॉलेज में तो क्या कोई प्रोग्राम देता है उसको? नहीं देता है ना. तो वी शुड हैव द कैपेसिटी टू बाय इट फ्रॉम आवर ओन इंस्टीट्यूशन और फ्रॉम द स्टेट फंड. सीटीडी बहुत कोशिश करता है, दे हैव फंडेड मैनी थिंग्स. अभी तो क्योंकि अभी आवर फोकस इज ऑन early diagnosis and treatment, where we are not being successful at all. So handheld X-ray they are buying. So I can say that one handheld X-ray is equivalent to one therapeutic monitoring HPLC. Okay. So second thing, 20% of medical colleges in the country, they have got HPLC. Somewhere it is in the Department of Pharmacology and somewhere it is in the Department of Biochemistry. So yesterday also I visited RMR, it was in the Department of Biochemistry. But they said that it's not compatible for tuberculosis. So it is a question of reagents. So we should just focus on the availability which is there. Of course, one agency of Government of India, that is Department of Health Research through ICMR, Multidisciplinary Research Unit. There it is a provision to buy equipment worth 3-4 crore rupees, and many state has been able to buy the HPLC through this fund. So we should try in each state. I don't think in near future CTD will be able, because Dr. Urvashi promised and Dr. Padma at that time promised that I will train everybody wherever this machine is there. But right down the line, 4 years have passed. So we have to think, we have to see whether we can acquire these equipment. Is a total 15. Madam sitting on right side of you, I don't think the basic machine costs more than 20 lakhs. So we should think in the direction. So it was a wonderful case presented by the department. So I thank the presenter for wonderful presentation. I thank Dr. Kamal Chopra for his expert comment, Dr. Salil Bhargava. So I could see him after many days, of course, online. Then, of course, Dr. Rupak. So Rupak has been my idol. I will see that. So that is why I could say that we should try at institution level to procure, and then we should request, because when an institution can buy a robot machine for 5-6 crore of rupees, then why not this 15 to 20 lakhs rupees being spent on HPLC? We should try in this direction. So we also whenever we meet in Center TV division, we also will also advocate for that. Okay, na? So Dr. Singla is more advocating than me. So we will try from them, but in the meantime, we should also try at our own level, local institute, medical college. At least we can say about medical college to procure. It's not much an amount. So thank you very much. Thank you very much for giving me a chance. It was a wonderful presentation. Thank you.
Yeah, thank you very much, sir. So with this, we close our clinic. We request you to give the feedback. You can see the link in the chat box. So kindly give us the feedback. Thank you. Thanks a lot. Thank you.